Yeah, you can start, sir.
Yes. Please, Dipen, can you put on
Yes,
our flag?
just 2 minutes. I will
Yes.
make the live, then we'll share the screen.
It's, very happy Ganpati Chaturthi, sir. Ganesh.
Yeah, I didn't realize. I just went off my mind today. Sorry.
Issue, sir. Yeah, because this one is our private forum session, so we are as per our audiences and all our platforms. So nothing to worry about that. It's not. Sir, very good evening, sir. One of the great stalwarts in OBGY practices and well-known name in our ISA national and all over world also. Dr. Sunil Pandya, sir, is on our platform today evening. Good evening, sir. First of all, from ISA City Branch Nanded. This is our case meet 33. We are keeping these sessions for our celebration of ISA Platinum Jubilee celebration year. With that, we are having our ISA City Branch Nanded is also Silver Jubilee celebration year going on. So on both of these things, we started this case meet weekly on Friday 8 p.m. Today's topic is post-dural puncture headache, current concepts by Dr. Sunil Pandya, sir. He is a chief department of anesthesia, perioperative medicine and critical care, well-known hospital, AIG hospitals, Hyderabad. Sir is visiting consultant department of obstetric anesthesia, pain medicine and obstetric critical care, Fernandez Hospital, Hyderabad. This is also very well-known hospital. Everybody knows in India. Sir is director, Century Super Specialty Hospital. Sir is a chief advisor and visiting consultant at obstetric critical care unit, Century Hospital. Visiting consultant at Asian Institute of Nephrology and Urology and City Neuro Center, Hyderabad. Sir is a founder director of Prerna Anesthesia Group and Critical Care Service, established in 1997. Trailblazers in teen practice, concept introduced for the first time in the country. Sir is from Hyderabad, Telangana. Sir, most welcome on our platform, sir. Please share your screen, and its screen is now yours, sir. Please.
The screen is visible?
Yes, sir. Yes, sir. It's visible.
At the outset, my apologies. It totally went off my mind today as in the Ganpati Puja. But thank you very much, ISA Nanded, the official team bearers, and congratulations for the Silver Jubilee celebrations. So next few minutes, I shall be talking on the management aspects of post-dural puncture headache in obstetrics and what are the current concepts. I say management of Pdph in obstetrics has taken a paradigm shift, and that's what I'll be talking next few minutes. Greetings from Prerna Anesthesia Critical Care Services. We are a team of about 107 anesthesiologists and critical care specialists covering 12 hospitals in the city. And how many of you have encountered this situation when you're doing an epidural? Well, I don't have the audience poll, but yes, not infrequently we encounter the situation wherein inadvertent dural puncture or wet tap happens.
Sir, sir, I want to interrupt you.
Yeah.
Please share your screen, sir. There's something of DigiShields coming on. Actually,
screen is on. Is it not?
It's your presentation only... is not able to view.
Okay. Is it visible now?
It's showing DigiShields platform.
One second.
So please open your presentation.
Yeah. See. Share my screen.
Yes, now it's coming, sir.
Is it coming
AIG, now? Yes, AIG greetings from AIG. Yes, sir. Now it came, sir.
So basically, the management of post-dural puncture headache in obstetrics, current concepts we have had a paradigm shift in management of PDPH and the incidence of PDPH in our hospital. And I shall be sharing our experience and what the literature says and the current concepts. My apologies to ISC team members and congratulations once again. Greetings from our team at Prerna, which we cover about 12 hospitals with 107 anesthesiologists and critical care specialists, 24/7. So many a times, or probably I don't say many a times, but not infrequently, we encounter the situation where we are setting an epidural for a surgical procedure or a laboring parturient for painless delivery, and we encounter the situation where you see CSF dribbling out when you're putting a TUV needle into the epidural space. Well, this is a situation which leads to panic, and we well known, we call it as a wet tap. And this is what is important. It is important from an anesthesiologist perspective because in the recent maternal audit review, the critical audit review, maternal mortality review in the United Kingdom, there were 2 maternal deaths from PDPH, 2 maternal deaths because of post-dural puncture or wet tap, and 11% of medical legal claims are because of PDPH, either improperly managed or complications of PDPH. And this is from the closed loop, a closed claim analysis. And women who died because of postural puncture headache, basically blood patch was given, and both the women experienced headaches of some weeks before emergency presentation that turned out to be cerebral venous thrombosis in one case and subdural hematoma in the other. So we know that wet tap or PD post-dural puncture or the accidental dural puncture can result in devastating complications if you don't manage properly. But of late, yes, the improved technique, the learning curve has gone up among the anesthesiologists, and we see paradigm shift. We have moved from Quinky to Whitacare. In fact, we abandoned the usage of Quinky almost about a decade ago in obstetrics, and now we solely use pencil point needles even in non-obstetric patients. And this has tremendously reduced incidence of PDPH because we know that about 95% of procedures, obstetric procedures, be it cesarean sections, emergencies, or stat cesarean sections, or elective sections, we do it under spinal anesthesia or combined spinal epidural anesthesia. And when it is spinal, majority of the time, I remember as a postgraduate, we used to use 23, 24 gauge needle. When we started our team practice, we switched over to 26, 27 gauge Quinky needle. But almost about a decade ago, we switched over to Whitacare since the time it is available. And we feel that it has tremendously helped us in reduction of postural puncture headache. I would say that if the spines are good, if you're an experienced person, the incidence of PDPH is 0% with 29 gauge Whitacare needle. 0%, not a single case we have encountered. But yes, using 29 gauge needle sometimes can be challenging and sometimes it is difficult. But 27, and even if you are using 25, 27 Whitacare, a pencil point needle, the PDPH incidence is less than 2.5 to 3%. So one of the paradigm shift that has happened is switching over from Quinky to pencil point needles. And once you have experience and you have the mindset and the change of mindset, definitely that is one important step towards minimizing incidence of PDPH following spinal anesthesia in obstetric patients. Because many a times we are used to one set of procedures using Pinky 25, 26. You say we have used 26 gauge, I have used 27 gauge. Doesn't matter. We have seen severe PDPH following 27 gauge Pinky also. So please change to pencil point needles, and that is one of the important steps in minimizing PDPH. This is one of the beautiful article in 1918. It was in Lancet, where they were depicted that the dural puncture, the hole is there, and this is the lateral view wherein you see puncture created by the spinal needle. Then it was about 18 gauge or 17 gauge spinal needles were used, and you can see the CSF dribbling out of the dural hole. And this was a pictorial infographic appeared in Lancet in 1918. And we have a data of almost 1.5 lakh parturients where we have given regional anesthesia. And this is what the statistics of our institute, they say. So basically, this was the study that we did, a retrospective analysis from 1997 when we started our team practice. And then we have been auditing our data, and I shall be talking our data with what the current literature. So if you see, we did this audit with the approval of IRB, our ethics committee board, and these are the acronyms that we have used in our presentation. And this was a retrospective audit from 1997 to 2021. And as I said, nearly 1.5 lakh, 1.42 lakh patients were analyzed. And the data, this is our dashboard, a clinical dashboard where we analyze more than 93 peripartum perioperative parameters. And we have been doing this year on year. And this is what the data. So overall incidence of dural puncture, accidental dural puncture in our institute was 0.48%. And incidence of Pdph following accidental dural puncture is almost 43%. So many times we see that I have not encountered Pdph in my practice. I do so many epidurals. So if you have to encounter a dural puncture or a wet tap with a TUI needle, either a 16 gauge TUI needle or 18 gauge TUI needle, the incidence is almost about 45 to 50%. Some institutes and some literature suggest almost as high as 60%. But overall, our incidence is about 45 to 50%, and the dual puncture rate is 0.4%. And currently, we are cruising at 0.2% incidence. And if you look at the study, what we have done is we have divided our study in three phases. The first phase, 1997 to 2004, and second phase of 2004 to 2017, and phase 3 is ongoing. So 1997 to 2004 is when we encountered a dural puncture, we used to remove the needle and reset the epidural in a space above. And 2004 onwards, we started using intrathecal catheter. So the moment you encounter an accidental dural puncture, we used to give the analgesia. So what is the protocol of wet tap? I'll come to it a little later. But basically, what we do is whenever you encounter a wet tap, the knee-jerk reaction is pull out the TUI needle. Instead of that, what we do is we push the stellate back into the TUI needle. So stop the leak. And now you have time to think. And the thing is, suppose if I'm doing a labor epidural, I give a laboring dose into the through the TUI needle into the subarachnoid space. So first of all, the objective of inserting a epidural needle into the neuraxial compartment is achieved. That is pain relief. And if I'm doing a surgical case, I inject the local anesthetic, like suppose a cesarean section, I inject 10 milligrams of bupivacaine hyperbaric with 20 mg of fentanyl and achieve analgesia. And then subsequently, I have time to think whether to remove the TUI needle and thread in a space above or thread the catheter inside. So first and foremost, my protocol or my advice to all our colleagues who are practicing regional anesthesia is, if you encounter wet tap, no need to panic. We are humans. This can happen to anybody. So what we do is, again, as I said, plug the leak. That is, put the stellate, stop CSF leak, then load the drug that is intended for the purpose. If it's a laboring parturient, we use 20 mg of fentanyl if the pain scores are less than 7. If the pain scores are more than 7 to 10, in the VAS score of 7 to 10, we use 20 mg of fentanyl with 2 to 3 milligrams of preservative-free ropivacaine. Fortunately, we have preservative-free local anesthetic available now. We have bupivacaine available, levobupivacaine, and ropivacaine. So 2.5 to 3 milligrams of ropivacaine with 20 mg of fentanyl in a laboring parturient, if it is a labor dose. And if it's a surgical case, you use a surgical dose. One more advice here. So many times what happens, if you look at the tip of the TUI needle, the Huber point is a concave point of 0.5 or 0.6 millimeters width. So many times what happens, the tip of the TUI is in the subarachnoid space, and you start looking at, you start the CSF, you see the CSF leak at the TUI needle, at the hub of the TUI needle. So what we do is, whenever you see a wet tap, you push the stellate completely inside it and advance the needle further. Advance the needle further, because many times it's only the tip of the needle is in the subarachnoid space, and the concavity of the TUI needle may be in the subdural space or in the epidural space. And you may have a partial spinal block, or you may have a subdural block. So what we do is, the moment you encounter a wet tap, insert the stellate into the TUI needle, advance the TUI needle by couple of millimeters more, do a complete wet tap. हो गया सो हो गया, कुछ करना नहीं है. So now make a complete wet tap, Then you inject the drug, appropriate drug, either for laboring dose or for the surgical dose. And then one more important step, the fixation time of local anesthetic, that is bupivacaine, to the neuraxial tissue is about anywhere between 2 minutes to 18 minutes. And the fixation time of fentanyl, fentanyl is a lipophilic agent, because of its lipophilic nature. But so what I would suggest is, the moment you inject the drug, do not disconnect the syringe from the TUI hub. You engage the patient with a conversation, allow the drug to fix. Couple of minutes later, you disengage the syringe from the TUI hub, and then quickly allow the thread the catheter for 3 centimeters. I hope I am clear. So I'll again repeat for the sake of audience. The moment you encounter a wet tap, do not panic. Plug the leak by putting the stillet. Load the appropriate drug, either surgical drug or a laboring drug, depending on the type of case you're doing. And then insert the stillet completely into the TUI needle and advance the needle by a couple of more millimeters so that the entire TUI needle is in the subarachnoid space. Once the TUI is in the subarachnoid space, then you inject the appropriate drug. Make make no mistakes in giving appropriate drug. See that you read the ampule 3 times, appropriate drug, appropriate dose, inject the drug. And then once you inject the drug, do not disconnect the syringe from the TUI hub, because the moment you remove the inject the drug and remove the drug which is there in the submarine may just flow back and you may not have a complete effect. So allow the drug to fix to the neuraxial tissue, and after 2 to 3 minutes later, disengage the syringe from the TUI hub and occlude the hub with the thumb, left hand thumb, and then thread the catheter inside for 3 centimeters. That is intrathecal catheter. And this is the protocol that we have been following since 2004 onwards currently. Okay, so I'll come to our data. So basically, management of wet tap is very, very important. So our secondary outcome of our study was to study the incidence of failed or patchy block subsequent pregnancies, acquire the data of Pdph following unwitnessed wet taps. That is another important entity. Many a times we see that your procedure of epidural was uneventful, totally uneventful. There was no wet tap, but still the patient has classic signs and symptoms of Pdph. So unrecognized wet taps are not uncommon. These are known as occult dural punctures, and there is no documented evidence of ADP. We don't see CSF. You have a catheter that goes into the epidural space. You have a fantastic epidural effect, but the patient has Pdph. So I'll come to it little later. And we are also studying the long-term sequelae of Pdph and epidural blood patch, which we are whom we have encountered. We also have a subgroup analysis where we used to give prophylactic blood patch and outcomes, a volume of blood to be injected, epidural blood blowouts, and repeat blood patch. These are the things that we have done in our study. So if you look at the total number of epidural wet taps that we have had in phase 1, that is 1997 to 2004, about 105. So basically the incidence was 46.6%. And the number of patients requiring conventional blood patch was 32.38%. And if we look at again prophylactic blood patch, see, a majority of the patient, as I said in phase 1, we reset the catheter in a space above. Like what we did is, the moment we encountered the wet tap, we removed the TUI needle, inserted in a space above. All the catheter, we never threaded the catheter inside. And if you look at VVIP patients, we thought patient is going to create a lot of nuisance. We gave prophylactic blood patch. And number of patients requiring bleeding blood patch after prophylactic blood patch, almost 12%. So we abandoned this technique because some of the patients, like as I said, following a wet tap, 45 to 50% patient develop Pdph. 50% of patient may not develop Pdph. So it is very difficult to gauge whether this patient belongs to 50% of Pdph or 50% non-Pdph, and unnecessarily you may end up giving a blood patch in a patient you may not experience Pdph. So we abandoned this prophylactic blood patch in 2004 our practice. Then if you see 2005 onwards, we started threading the catheter intrathecally. wherein when the moment you had a wet tap, we threaded the catheter intrathecal and managed it as intrathecal catheter. And then if you look at the incidence of patients requiring blood patch of 7%, with like if you see here, it was 32% of patients required blood patch, whereas when you threaded the catheter intrathecally, only 7% of participants needed a blood patch. That means there was a tremendous reduction in incidence of epidural blood patch in patients where intrathecal catheter was injected. We started threading the catheter intrathecally because the parturients that came to our center were morbidly obese, problematic cases, multiple comorbidities, and often they had backs where they had adiposity or morbidly obese or edematous and boggy back. And hence we put a protocol of threading the catheter intrathecally. So if you look at the incidence of blood patch in catheter where resided in a space above versus intrathecal catheter, it was statistically significant reduction in blood patch. So this is very important. So one of the thing is, whenever you have accidental dural puncture, you have two options. Option one is you reset in a space above. Option two is you thread the catheter intrathecally. The protocol that we follow is thread the catheter intrathecally and manage it as a spinal catheter. And we retain the catheter for 24 hours, remove at the end of 24 hours, and incidence of Pdph and blood patch falls down in a statistical significant way compared to those where the catheter is threaded above. That is one of the take-home message. But yes, it comes with a rider. The rider is because you are threading the catheter intrathecally, there is a possibility of neuraxial infections. The infection rate might be there. So you have to take utmost precautions. And second important thing is inadvertent wrong drug being injected in the post-operative ward or in the ICU or in the ward if the patient is shifted to ward. So what we do in our hospital is we strap the catheter, we lock the catheter, and we give in a red bold letters, we type that no, do not inject any drug, and we tell the patient, see that no drug is injected. So this part of the thing has to be instructed and documented. Other important is, does epidural fail after blood patch? There's another thing that we analyzed. So because we are getting third generation patients and fourth generation patients, patient had epidural, her daughter had epidural, and daughter's daughter also had epidural in our hospital, because three generations have come, even a fourth generation are coming now, because the fertility rate among some sect of people is very high, and we have seen even 4 generations. So we did encounter a few patients where patient had epidural blood patch was given in the previous pregnancy, and they willingly took epidural because they felt that Pdph was less severe because we managed it. I would take accolade for that properly, and patient felt that the post-dural puncture headache was not that severe compared to labor pain. And initially we thought post-dural, I mean, a blood patch can cause fibrosis, can cause adhesions, or can cause bands in the epidural space, and epidural may fail. But I must tell you that not a single, we must have done about 25, 30 epidurals in parturients who had blood patch in the previous pregnancies or previous deliveries, and not a single failed epidural after a blood patch. So the point again, second take-home point from our experience says that the epidural need not necessarily fail after a blood patch, contradictory to the literature. This is our experience. So with number of patients who received blood patch and came for subsequent delivery, almost 27. And we counsel gave epidural, combined spinal epidural in 23. Those who refused epidural 4 and patchy or failed epidural were nil. So this is one of the important take-home message. So that is one important thing. Other important thing is epidural blood patch a gospel truth? Is it a holy grail? Well, yes, majority of the time, one blood patch gives fantastic pain relief almost to the extent of 70 to 80%, but patient may not have 100%. So when you are counseling the patient for a blood patch, always tell them that there is a possibility that one blood patch may not be sufficient and patient may need one more blood patch. And that is that thing you have to keep in mind. And the incidence of repeat blood patch, I would say, is about 7% of patients or 9% where they received repeat blood patch. and we have not had any third blood patch. The blowout occurred in 2 patients. Blowout in the sense, once the patient had blood patch, fantastic pain relief. They were so happy that they started almost running, jogging, walking, and the constipation has led to epidural patch blowout, and which necessitated a repeat blood patch. So basically, once you do a blood patch, see that the patient is given proper laxatives, and they don't strain during passing of stools. Very, very important. What we realized earlier is volume of blood injected was not standardized earlier days of our practice, but subsequently from 2005 onwards, whatever cases we have encountered, we have standardized our blood volume of 20 ml is what 20 to 23 ml is what is the endpoint of blood patch. And generally, we do blood patch one space lower than the dural puncture. So suppose if you are doing liver epidural or surgical epidural at L3, L4 space, the blood patch should be L4, L5. So one space down, so that when you inject, the blood generally goes capillate and it should form it should plug the leak. So this is what the diagram is. So basically, initial days, the volume of blood that was injected was less. And as we gained more experience, we made about 15 ml, 18 ml, but now we give almost about 20 to 23 ml of blood into the epidural space, and that effectively plugs the leak. So a high volume blood patch, you should not inject more than 25 ml. The end point of injection is whenever you're injecting blood, there is a referred pain either in the buttocks or in the knee, and that is the end point of your injection. Even otherwise, if the patient does not have pain even after 23 ml, you stop at that moment of time. You have to be very careful. So there are certain do's and don'ts when you're doing blood patch. Whether you have to take a consent, yes, consent has to be taken. And what do you explain to the patient? Explain that yes, the blood patch gives a good pain relief, almost about 75 to 80%, but 10-15% it may not be sufficient. One blood patch, you may have to have a second blood patch. That has to be explained. And are there any complications of epidural blood patch? Short-term complications like heaviness in the back, short-term low backache, yes, might occur. But long-term complications, generally low backache is remote, may not happen. But a small chunk of patients can have long-term headache, especially if the initial headache is not treated properly. So why that long-term headache? So this was a beautiful study that came in Current Opinion, probably in 2018, which said that if you delay blood patch beyond 72 hours, then the relief may not be adequate. So ideal time of blood patch should be between 24 to 48 hours. So first 24 hours, too early blood patch also may not give pain relief, and too late blood patch also may not have a complete pain relief. So ideal duration of ideal timing of blood patch should be 24 to 48 hours. Now, which are all the patients that need a blood patch? Again, the moment you encounter a wet tap and all those things, once the parturient delivers, always once the happy moment is done and the parents are happy, go to their room same day or the next day morning, examine the patient upright posture, because many a times we see that our residents, junior fellows, they go to the patient room and they say, sir, this patient is not having headache, she's comfortable. But the patient was in a lying down position. The resident has examined the patient in lying down position when she was feeding or she was sleeping. So it is very important and crucial that you make the patient sit and examine. Again, don't ask any direct questions because they are little emotionally labile parturients. The pregnant patients in the postnatal period are very labile for several reasons. If they wanted a male boy and they get a female child, they're unhappy. If it's a preterm delivery, they'll be unhappy. If it's a postnatal pregnancy, they may child is in NICU or observation, they'll be unhappy. There are several factors. Lack of sleep can also cause headache. There are about 20 different causes of postpartum headache. So you need to make a right diagnosis whether it's a postural puncture headache or postpartum headache of different etiology. So the sign qua non of PDPH is postural element. You may have headache, pan headache like bifrontal, bioccipital headache, which worsens with upright posture and ambulation and resolves during supine position. So the resolvement in supine position is almost to the extent that more than 80% of pain resolves. And there is a sign canal of postural puncture headache. So there are certain three other headaches which are postural. One is cerebral sinus venous thrombosis headache. Other is subdural hematoma. So subdural hematoma, cerebral sinus venous thrombosis, maxillary and bifrontal sinusitis, they're also postural headache. But the differentiating point between PDPH and other headache is the PDPH diminishes by 80 to 90% when the patient assumes supine position, whereas CSVT, sinusitis, or even subdural hematoma, when the patient assumes supine position, the headache may not reduce completely, may reduce by 10 to 15% only. So that is one of the differentiating features. And many a times, whenever there is an intracranial pathology like subdural hematoma or CSVT or a press syndrome, which type can lead to, they have certain other lateralizing signs of sixth nerve palsy and other things. So you need to have a thorough clinical assessment. Is it meningitis? Is it chemical meningism? Is it CSVT? Is it postural puncture headache? Or is it lactation headache? Or is it lack of sleep that is causing headache? Or is it because of any drug-induced headache? There are so many excessive prolactin or dopaminergic antagonists which the patient can give. Gabapentin can cause severe headache if they want to stop lactation. So you need to analyze each and every cause before you diagnose. So it's very, very important that you right diagnosis, right timing of blood patch, right volume of blood patch is very, very important. This is again an electron microscope picture taken in 1918 Lancet. You see the ragged edges of dura. This is a picture where epidural blood patch was done in a dog actually. So this is an electron microscope picture where you see ragged edges of dura, and there's a blood that is injected into the epidural space, and you can see the blood in the epidural space with a clot plugging the CSF leak. Beautiful picture taken up in those days. So this is what is important. So coming back to our own data, the number of patients coming back with subsequent deliveries 27, and as I said, all we had given epidural and there were no failed epidural blood patch. And fortunately, we started collecting the data of long-term chronic backache and headache. We could reach out telephonic feedback, especially all these 27. Of course, they came back and there were no headaches, but remaining, yes, we couldn't reach out a small number, but a long-term backache, long-term headache, fortunately, is less. Now, is blood patch the only answer that is available to treat PDPH? No. Not all patients require PDPH. Not all patients require, not all PDPH patients require blood patch. So what are all the patients who require blood patch? I said severe headache, intolerable headache. The moment the patient gets up and she's not able to sit upright for beyond 1 or 2 minutes, then those are the patients who need headache. And that too, you give analgesics like brufen, paracetamol for 24 hours. If they don't subside, then 36 to 48 hours is the ideal time. But yes, if the headache is of moderate intensity, they're able to go to washroom, they're able to do their morning ablutions, she's able to go to neonatal ICU to feed the child, but has discomfort. So VAS score is around 5 to 7, but manageable. So those are the patients where you can try alternate modalities. So what are the alternate modalities? One of the alternate modalities, injection cosintropin. This was basically ACTH analog, and it is available in the market, and the dosage is 0.25 milli. It comes in vial of 0.25 milligrams, but the recommended dosage is 0.5 milligrams. I mean, the study which came for the first time in anesthesiology 2010, where they have given cosintropin injection prophylactically. Prophylactically, it was given, and they found out that the reduction in headache with usage of prophylactic cosintropin was almost to the tune of 30%. And they felt that this drug has to be given. The dosage they had used was 1 milligram. What we have used is, we have not used prophylactic cosintropin because of the cost constraints. But when the patient has moderate PDPH, we give about 0.25 milligrams intravenous cosintropin 4 hours apart, 2 doses, and it is helpful. It has reduced the headache, PDPH. So the contraindication for cosintropin is uncontrolled diabetes, because it is an ACTH analog. It's a steroid-like activity. How does it act? But it promotes the excessive production of CSF from at the subarachnoid villi. So excessive production of CSF causing balancing or CSF, whatever it has leaked. So to an extent, it mitigates the Pdph. So to an extent, it can help in minimizing Pdph. Sphenopalatine block, for the first time, this was a revolutionary paper that came from a US Indian anesthetist, I think Dr. Patel published this paper, and he said goodbye to blood patch. The paper, the way the heading title was of the paper. But again, I must tell you that sphenopalatine block again has its limitations. It is a momentary activity. It basically you just have to dip a local anesthetic swab in a 4% lidocaine or 2% lidocaine and introduce into the middle turbinate, go posteriorly, and you hit the sphenopalatine ganglion and you block it. And basically it causes cerebral vasoconstriction, and that's how it relieves the headache. But yes, we have used 11 cases. Only transient pain relief is what we observed. And PDPH following TUE needle, it may a patient may have to put this thing at least 2 or 3 times a day for 2 to 3 days, and eventually it may subside. But so post spinal headache, like twinkie needle headache, sphenopalatine block may work. But for TUE needle, if the patient has severe pain, then this may not be a right technique. But yes, there is one more technique that is available in the armamentarium. So the trend at our institute is, as per the worldwide data, we had past decade, 2 decades, we have, it has helped us tremendously to establish and standardize our protocol. So our protocol and what we recommend is thread the catheter intrathecally and manage it as a spinal catheter. There is a contradicting literature which says that intrathecal catheter does not help. And we have reviewed all the data of all this literature where the intrathecal catheter has not helped. That is a Western study. But if you look at our institute, the same team, the core team of us, about 6 members, we are there since 1997, and we have been at the same institute and same place. So modality of assessment, modality of patient, the type of patients, the cohorts of patients, majority of the Indian subset, they are all same. And that is probably one of the reasons why we say that intrathecal catheter placement for 24 hours definitely is a fantastic modality to reduce the incidence of intensity of PDPH, and definitely statistically significant reduction in postural puncture headache by intrathecal catheter placement. Yes, as I said, one rider is incidence of infections. So you have to strictly ensure that no wrong drug is given, and the catheter should be strapped, and patient has to be told that nothing goes into the catheter, and catheter has to be removed at the end of 24 hours. So the clear documentation has to happen. And this is what the recent audit, where like this is our dashboard audit, where our hallmark is our current incidence is 0.2%, and the moment it goes beyond 1%, we have an alert, and this helped us in reducing incidence of PDPH. So the parameter that we analyze in our dashboard is a number of accidental dural puncture with epidural, with combined spinal epidural, where intrathecal catheter was placed, where epidural was relocated in the space above, PDPH with EA, PDPH with CACA. And the clinical audit parameters is severe PDPH after intrathecal catheter, after a different space, PDPH with press syndromes, those who are conservatively managed, those who require blood patch, epidural blood patch with long-term sequelae, epidural blood patch with long-term sequelae headache and long-term sequelae backache. So these are all the parameters that we have been monitoring since 2010. This is from 2010 onwards, and you can see year on year the data is being analyzed. So I would conclude that ITC, intrathecal catheter placement, is numero uno technique of minimizing blood patch, leads to significant reduction in EBP, nil infections, but mandates strict asepsis. Resetting the catheter in the space above can be an option in at least in nursing homes where strict asepsis cannot be guaranteed. But yes, it comes with a higher incidence of PDPH, higher incidence of conventional blood patch that has to be recommended. Prophylactic blood patch no longer recommended, should be condemned. Sphenopalatine block definitely not for severe PDPH, but yes, it is a option that is available. So as I said, ours is a single center study, more than 2 decades, single team, same assessors, similar cohort, and I felt this is a gold standard intrathecal catheter to minimize PDPH. So gold standard for moderate to severe PDPH is blood patch. Yes, if the patient has blood PDPH, then gold standard is blood patch, not sphenopalatine block. Ideally administered within 24 to 72 hours, not beyond 3 days. Good infection control policy has to happen. Post blood patch, blowout can occur, especially if the patient resorts to heavy exercises, brisk walking. So prevention of constipation, prescribing stool softeners is very, very important. And patient has to be told that they should not carry heavy weights. Yes, they can definitely carry their baby, but not heavy weights. That is very, very important. So the take-home message is prevent the first, that is accidental dural puncture. And when you have accidental dural puncture, as I said, our protocol is do not panic. Plug the leak by putting the stellate. Then load the appropriate drug. If it's laboring parturient with VAS scores of less than 7, 20 mg of fentanyl. And if the laboring parturient VAS score of more than 7 to 10, then 20 mg of fentanyl with 2.2 to 3 milligrams of preservative-free ropivacaine. And then what I do is, or what we recommend is, insert the stellate completely in the TUI shaft, advance the needle by another 2 millimeters. Because as I said, the Huber point, concave point is about 0.5 millimeters. So it might be that only the tip of the TUI needle may be inside the subretinal space, and you see CSF, and subsequently you may have a patchy block or a failed block. Despite having a clear CSF. So advance the needle completely into the subarachnoid space, then inject the appropriate drug. And once you inject the drug, do not disconnect the syringe from the TUI needle. Allow the drug to fix to the neuraxial tissue, at least 2 to 3 minutes. And then disconnect the syringe from the TUI hub, occlude the TUI with the thumb of the left side, and then thread the catheter intrathecally for 3 centimeters, not beyond 3 centimeters. And then strap it and see that you manage it as a spinal catheter. And as I said, spinal protocol is for 2 hours, the patient may not need any analgesia. It's a laboring parturient. But if the patient continues to be in labor, then what you can do is you can connect the infusion pump. So what we do is 20 ml of 0.1% ropivacaine, 20 ml of 0.1% ropivacaine, and 100 mg of fentanyl. We make it 50 ml total with saline in a 50 ml syringe, and run at 2 to 3 ml or 3 to 4 ml per hour, depending on the laboring progress of labor. So intrathecal catheter not only helps to provide adequate analgesia, but also it prevents the excessive CSF leak that can happen at the time of delivery. Let us say, imagine that you have threaded the catheter, you have removed the TUI needle and threaded the catheter in a space above. So you have a catheter in a space above, and you have a dural hole which has happened in the previous attempt in the space below. So when the parturient is straining at the time of delivery, there is CSF leak increases, and that can also increase high incidence of PDPH. So by plugging the leak with catheter, this process of excessive CSF leak also can be minimized. And that is one of the reasons why the incidence of PDPH is relatively less with intrathecal catheterization. So prevent the accidental dural puncture by going up the learning curve, and treat the second, that is PDPH aggressively. Document it properly. Several options are available. The medical options are either, as I said, NSAIDs like Brufen, paracetamol. Caffeine again is not recommended, because the dosage that is required is almost more than 1 gram per day, and that can cause severe cerebral vasoconstriction. And there have been instances where there have been caffeine-induced seizures also. So simple Brufen, paracetamol suffices. If it doesn't suffice, then you can use cosyntropin. But theophylline, daraphyllin, sumatriptan, all have been tried with less success. But as I said, cosyntropin definitely, there is an evidence that it helps because it enhances the production of CSF fluid. But so that is what. If you are giving a blood patch, see that the blood patch is about at least 20 to 25, 20 to 23 ml. So key takeaway from my talk is you have a clear-cut policy of management of wet tap. Atypical headache can occur. So you can have a PDPH with one more additional entity. Be aware, beware. So as I said, subdural hematoma, civil sinus venous thrombosis, press syndromes, maxillary sinusitis, worsening of migraine, lactation headache, insomnic headache, lack of sleep. So there are so many different causes that you have to analyze. So atypical headache can occur, which may mimic PDPH, and you may end up giving a blood patch in a wrong case, and it can have sequelae. So imaging can help. So imaging CT scan, plain CT scan of brain is useless. It does not reveal anything. Either you go for a contrast CT, which can diagnose SDH, but I would recommend MRI of the brain with MR venogram as a very useful imaging modality. Too early imaging, you can miss out. So ideal time of imaging at least is 48 hours after the onset of PDPH. If it is too early, then you may miss out the pathology. You may not diagnose it. The accidental pleural headache can be associated with chronic headache. So management of headache within 24 to 72 hours is ideal. Switch over to pencil point needles. Switch over to intrathecal catheter placement with stick asepsis. Sphenopalatine block, as I said, for short-term headache, post-spinal headache can help, but long-term headache may not be sufficient. But you may have to use multiple times. And clinical audit of your data is very, very important. As I said, we started the phase 3 from 2018 onwards. So here, what we are evaluating the sphenopalatine block again in whenever we have a case. And so far, 2018 to 2022, again, I would say my takeaway is still not a great technique for following epidural PDPH, but yes, for post-spinal headache, a short-term headache, it can definitely help. And stringent post-PDPH follow-up is very, very important. And there have been newer modalities where newer drugs have been tried, like addition of neostigmine and atropine to conventional management of PDPH, because neostigmine also is known to increase CSF production. So it also helps, and the dosage that is recommended is about 1 milligram of neostigmine with 0.6 mg of atropine has been used, but again, we have used only in 2 cases. It has not helped. So, but again, we need to have a large volume. This was a beautiful paper by Michael Peach et al., where this was an atrial iatrogenic headache. Post-dural puncture headache is an iatrogenic headache following accidental dural puncture. It gives sore head to all the anesthesiologists. So the conclusion of this article was fantastic. When you go to bed with clear head, you will not get up with any headache. So what I want to emphasize is there are several strategies that are available to manage PDPH. So if you are clear in your mind, this patient needs blood patch, this patient does not need blood patch, this patient will benefit from this technique, this patient will benefit from this technique. So options are there, and you need to choose right option for the right patient, and patient may not get any headache, and you will also not get any headache. This was an electron microscopic picture of dural puncture, how the dural puncture leaks. Again, this was a recent picture that came in Naisura in 2000 and probably 15. So do not have this, otherwise you end up with a large hole into the dura. Thank you very much.
Thank you, sir. Very nice to hear from you a lot of things about PDPH. So much dilemma on this in our private forum. Most of the people you mentioned drug like derifylin, sumatriptan, and all this.
Sir,
they use a lot of times. I also do same what you mentioned like that, but related to Quinky, not in to his needle.
yeah.
We are having so much problem with Quinky needles.
Yes.
We got PDPH in that point of view. So I will be happy to ask you one question from Dr. Naresh Paliwal, sir. He's asking, yes, sir, why not to convert it to CSA and keep the catheter in place for 24 hours?
We are using catheter intrathecal only, no?
Yes.
We are using the same thing. We are converting into the we are threading the catheter intrathecally and putting it for 24 hours.
Yes, yes, sir. Without any using drugs or
We use spinal, as I said, the protocol is
intrathecal drugs for,
yeah,
with catheter.
intrathecal drugs.
Yes.
And length of fixation is just 3 centimeters inside, not more than 3 centimeters.
Okay.
So again, as I said, repeated handling of epidural catheter leads to colonization of epidural catheter hub. So our protocol is we make a syringe infusion. As I said, 20 milligrams of ropivacaine in 50 ml. So 0.4 mg of ropivacaine per ml. And 100 mg of fentanyl in 50 ml saline. So ropivacaine 20 milligrams and 100 mg of fentanyl, and that is 20 ml plus 22 ml, 2 ml of fentanyl and 40 to 48 ml of, 28 ml of saline. So total about 50 ml of solution is prepared in a 50 ml syringe infusion, and we run this at the rate of 2 to 3 ml. That is about 2 ml is 0.8 milligram of ropivacaine and 8 mics of fentanyl per hour infusion course. So that's what the protocol is, and majority of the time the patients are comfortable. If this parturient comes for cesarean section, we disconnect the infusion and then give the surgical dose at 10 milligrams of bupivacaine with fentanyl, and then subsequently post-operatively we restart the infusion for post-operative pain management. Same infusion, so that we don't handle the catheter repeatedly, because we don't want colonization to happen. But as I said, this requires errors can happen. Epidural infusion can be connected, disconnected. So we just have to be sure that the anesthetist lingers around with the patient, because we have 24/7 services at our hospital. We follow this protocol. If it's a freelance practice, then I won't recommend this technique. You reset in a space above and manages at the epidural catheter. But again, you have to remember that when you are removing the tuhi needle and putting the tuhi needle in a space above, there's always a possibility that you may end up with second dural puncture. So the incidence of Pdph might increase logarithmically. And importantly, even if the epidural catheter, is animated in the space above, each drug you give may go into the intrathecal compartment via the dural puncture hole which has been created. So it's a multi-compartmental block can happen. So once you have a dural puncture and you are resetting in a space above, all top-ups have to be given by anesthetist only, because this top-up can go via the dural hole into the subarachnoid space and you can have a multi-compartmental block. You may have a high block. So that has to be kept in mind.
Sir, one question in chat box: which type of spinal catheter to be used? Do you use ultrasound guided EBP to avoid dural punctures?
See, definitely ultrasound has helped us in reducing dural punctures, especially in parturients with abnormal back. And also it helps us in selecting the widest and the best space. So, but so far in our experience, I must say that epidural has not helped us in minimizing the incidence of dural punches in our place, but at least it helps us in locating the best space. There is one thing. And second thing, as I said, ultrasound guided blood patch, ultrasound guided neuraxial space is as we select the space below when you're doing a blood patch. Suppose you have done a epidural in L2, L3 place, where I encountered dural puncture, my blood patch will be L3, L4, one space below, so that the trajectory of the blood when you're doing a blood patch is cephalic.
Yes, sir. One question in chat box again from Dr. Abhijit Nair, sir. Respected sir, wonderful presentation as always. Sir, most of the studies or reports of Pdph and its management are in obstetric anesthesia, mainly at lumbar levels. What is your experience and opinion about Pdph? Due inadvertent dural puncture at thoracic level, is it the same or there is any difference in severity, duration and management part?
Excellent question, Dr. Abhijit Nair. As I said, since 2018, as a team, I lead the team at AIG Hospital, wherein we almost, on an average, we do about 7 to 8 thoracic epidurals daily for a major surgical gastro procedures or surgical onco procedures. And yes, we have had few dural punctures. The incidence is probably again less than 0.2% or probably less than that, and 0% Pdph. So far, not a single blood patch we have done following thoracic dural puncture. The reason probably is because the spinal cord occupies most of the space, and it to an extent minimizes CSF leak. And second important thing which I felt is all were non-pregnant patients. We don't do thoracic epidurals in pregnancy. Yes, having said that, we have done thoracic epidurals in pregnant patient, probably about 15-20 thoracic epidurals for pancreatic pain management in pregnancy. But yes, we didn't encounter any dural puncture, those things. But dural puncture at thoracic level, the incidence of Pdph I have not encountered. Virtually, it's almost, I would say, 0% so far.
Yes, sir.
If you
Yes, sir. Yes, sir.
I would like to
Yes,
know.
sir. Because Naresh Paliwal sir is also here. I also comment on this. Is that he started doing segmental spinal anesthesia, and that topic is now is in private
Yeah.
forum. It's a very hot topic,
I,
and now we are also practicing that part. And I observe in my practice also, whatever I give lumbar and thoracic segmental spinals, in that PDPH is very much, nothing is there in thoracic segmental spinal cases, but in lumbar cases where I give pinky needle spinal, there is somewhat PDPH is presentable.
yeah.
Sir, one question from Paliwal sir also. Ropivacan, what concentration sir is mentioning about that?
Yeah, 0.1%.
Sir, Paliwal sir, you can speak you can unmute yourself and you can speak with sir also about your question if you want.
I must tell you that after listening to Dr. Paliwal, we have done few segmental spinals at thoracic level, but I'm still not very comfortable because we are a team of almost 20 people at AIG hospital, and not everybody is well versed. So, but having said that, we have done very challenging lap cholis in pulmonary crippled patients with lumbar, spinal, and thoracic epidural. And majority of the time, we didn't have to activate thoracic epidural catheter at all because the surgeons were very quick. Within 20 minutes, the lap chole was done. And one patient where the surgical procedure went beyond 45 minutes, 45 minutes duration, the patient started having shoulder tip pain, and we could manage with a mask, but we didn't have to give it. So shoulder tip pain is an issue. Probably, I don't know, even thoracic segmental epidural at thoracic level also may not mitigate shoulder tip pain in thoracic
Yes,
and
sir.
lap.
Yes, sir. It never happens. I experienced myself.
Yeah.
This- Sir is asking other question is what about the epidural catheter dead space? Do you take into account and whether flushing of catheter is done after each
If you
dose?
look at the epidural catheter dead space, yes, flushing of catheter is very important. A very valid point that you have raised. So what we do is when you're threading the catheter in a space, but the volume of air, if you see, 0.3 ml is the dead space of epidural catheter. The length of the epidural catheter is about 90 centimeters length, the conventional epidural catheter that we use in our commercial practice. And we just thread the catheter intrathecally. Yes, flush it with saline and then inject the drug. Is always even that 0.3 ml, 20 ml of air, why do you want to inject it?
I want to share one thought with all viewers that sir is very much open for any question on other than this PDPH also. If you
Absolutely.
have any question on other topic also, sir can share their thoughts and suggest you any questions from your side. Before that, I want to ask you, sir, related to backache. I got a lot of parturients post seizures. Here we using pinky needles, and a lot of time our surgeons also told some if patient goes for backaches and like that orthopedician, they went for orthopedician, he said are due to spinal isse wo ho gaya hai, and a lot of time when she came for next seizure, there is a lot of people, and she also told us, sir last time spinal diya tha wo seizure uski wajah se mera backache ho raha hai. What to do with this, sir? That
See,
thought.
first of all, there was a beautiful statement by Ostheimer. William Ostheimer is an anesthetist from, I think he's from Scandinavian country. Mm, Ostheimer, yes, from some Scandinavia. He has written a book in anesthetic management and pregnancy for cesarean sections. And one of the statement in Pdph chapter he makes is, due respects and regards to female colleagues watching this presentation or watching this webinar, he says that women are born with backache. Women are constipated bipeds, born with backache. This was the statement given by one of practicing obstetrician in the United Kingdom, which he quoted in the chapter. So basically, backache and headache are the most commonest symptom that a patient experiences in their lifetime. And we have to tell that we, in our own experience, I'll tell you the data of 1997 to 2000. We did a study. The same thing when we started epidural practice in 1997. We our optician started complaining, "Arey, isko backache aaya, isko backache aaya, isko headache aaya." And so what we did is, all backaches and all headaches, you tell us, we'll see the patient, irrespective of whether what type of anesthesia they received or whether they received anesthesia or not. We collected this data for 4 years, 1997, 98, 19, and 2000. And at least about 30% of patients were doctors, elite patients, and at least about, I would say, small chunk of patients were staff of Fernandez Hospital only. And when we presented the data, the incidence of headache, incidence of backache in parturients was more where GA was given, where no anesthetic intervention was done. No anesthetic interventions were done where GA was given. And that has cemented that permanently. Now, after 2000, they don't say that this patient got backache because of epidural.
Yes,
So what I mean to say is, backache can occur. Short-term backache can occur because of the local leg. Even if you are putting a Menfran in your hand, it causes little momentary tropical pain for a few days. Long-term backache is insignificant. So if the woman has backache during delivery, before delivery, the incidence of backache following regional anesthesia might be increased. But yes, you must tell that one of the modality of treating backache is epidural steroids and epidural interventions. So vehemently, you can deny that epidural per se does not cause any long-term backache. Pregnancy itself is a risk factor for backache because the lardose is the 9 months which is carrying, the effect of progesterones and estrogen on the ligaments, softening of ligaments itself can cause stretch on the sacroiliac joint and can cause severe backache. Severe backache.
Related to your Pdph in your institute, any medical issues happen?
So far, none. So far, none. Touch wood. But yes, there have been few instances where the husband and the family were sort of very
Aggressive about their complaints.
But as I said, we have, I can share the form which, let me see. We have a pamphlet wherein we explain to them that this thing can happen whether you want to take or not. Epidural, they go through this pamphlet. I'm not able to locate. We give them, we counsel them actually.
Okay, sir.
We counsel them beforehand,
Yes.
very clearly, and so they are already aware of that thing. And importantly, we make them sign our consent, which again mentions this headache, and we ask them that, do you have any specific questions? So a few of the things that are important is few things that are mandatory during our discussion is we tell them three things, that majority of the time epidural works wonderfully. First stage pain relief will be almost to the extent of 95 to 100%. But second stage pain relief will be about 40 to 60%. You may not have 100% pain relief. And I would say that when you say 40 to 60%, we give them the visual analog pain score chart. So when we measure with the women, when they take pain epidural, their pain scores are around the range of 9 to 10. And within 15 to 20 minutes after epidural, it drops to 0. So they have a very good correlation. Okay, my pain was this much. Now it is 0. At the time of second stage of labor, at term delivery, it will be between 4 and 6. So visually, they get a picture that this pain, what they need to anticipate. So that is one thing that we do routinely for all cases. Second thing, we say that at least 1 in 500, you may not have adequate pain relief. We may have to reset the catheter in that case. So that also they are prepared mentally that sometimes the epidural may not act to the desired effect, and we may have to reset the catheter, reposition the catheter. And third thing we mentioned about headache. So we tell them that yes, if you don't cooperate well, if you move during the procedures, there is a possibility that CSF may come out. Again, nothing much to worry. It can cause momentary headache, and it can be treated. Majority, there are multiple modalities, and depending on the nature, 60% of the time you may not have headache. 40% of the time you may either end up with conservative management. Some patient may require blood patch. So they may Google search what is blood patch and all those things. There's plenty of things they'll look into the Google. But fortunately, if they don't experience, it's fine. If they experience, it becomes easy. So explanation is very important. So once you have a dural puncture, then yes, again, once the patient has calmed down, has a baby, they are in a happy moment, go to them, visit them, examine them, and just tell that, yes, this was the thing that has happened, unfortunately, and we'll monitor you for headache. If you have any of those things, let us know. And don't ask direct questions. Objectively assess the patient. So when you go to the room next day, patient does not know that the headache worsens during sitting and it subsides during supine. So you make the patient sit, take blood vitals, check blood pressure, check pulse rate, check respiratory rate. The patient will feel as if you're checking the vitals and you're checking the instances. But indirectly, what I'm doing is I'm trying to make her sit as long as possible. And I can assess her. Then yes, I tell her to continue walking ambulation, and the moment she has headache, she'll call us. So we see the patient every 12th hourly, document every 12th hourly, and then before discharge, we see the patient, and then we give the phone number. In case of anything, just let us know. The documentation is very, very important. Assessment is very important. Don't wait for the nurse or for the obstetrician to call you to see the patient. The majority of the litigation following Pdph happens because you don't see the patient or on time, or you don't advise properly, or you don't talk to him properly, you don't document properly. So once you have a dural puncture, see that the protocol of documentation, repeated visits, not repeated to at least 2 times a day, and documentation is very important. And despite yes, some aggressive patients are always there, but how you talk and how you do, we have seen patients touching our feet following blood patch. So that also has happened.
Yes.
Yes.
So this is our ISA National Registry Week. Also, you can register your cases in that ISA app also, and in web also. Our secretary has started this thing. One question from our Aurangabad secretary. Ma'am is asking, sir, did you come across any share of breaking of catheters?
Touch wood, no. Again, I would like to emphasize that we have been doing, I don't know, but 2008, we introduced a device in our hospital for the first time probably in the country, where we started checking the tensile strength of the epidural catheter. So whenever you're checking the tensile strength, where the Young's modulus, if you recall the physics knowledge, so whenever you stretch any device, there is something known as yield point and break point. So majority of the catheters, they stretch 4 to 5 times than their actual length before they break. So it's like a rubber band. You stretch, there's a yield point. At some point of time, it breaks, snaps off. So majority of the catheters, like if you look at, again, I don't know conflict of interest, but the BD, the Braun, the Portex, they break when you apply a weight of 1.4 to 2 kgs of weight. That means you have to exert a pressure of 1.5 to 2 kgs
On
to
catheters.
break the catheter. And before breaking, there is a yield point. So when you remove the catheter, you have to see that the catheter is stretching. If the catheter is stretching out, you don't try to meddle with the, assume the, make the patient lie down in the same position, like flexed spine or flexed hip and flexion of spine, and then remove the catheter in that position so that it comes off easily. But suppose if the catheter, I don't again due respects and regards to our local manufacturer, there is no yield point. The local company, the moment you stretch the catheter, it snaps. So it's a brittle catheter. So in fact, we have converted, we have written a letter from the AOA when I was the president to the company, and they have modified, they have relaunched the catheter again this year, it seems. So I'm yet to, so we brought this device from IIT, Hyderabad. The youngster to take the tension on the catheter. So measure the catheter, they broke at 1.4 to
2 kgs.
2 kgs weight. And we put all this catheter at the temperature of 37 degrees, the body temperature. And we also created the ambient temperature in this lab, in vitro lab, of 40 degrees, because many a times the patient is 103, 104 fever, postpartum pyrexia can happen.
Yes, yes.
So the yield point increases further, but break point was same. So this is this. In fact, we are publishing this study very soon, even though this study was.
Really, sir, it's very nice thought that you shared with us, and it's really appreciable that this thing is happening at your side.
Yeah.
Really admirable from my side.
And one other thing, as Dr. Naresh Paliwal has mentioned rightly, if at all
Yes,
you're
yes.
not able to thread the catheter, do not pull out the catheter. Pull out the assembly. Very, very important. And again, I must tell you that some of the needles, like I won't name it, but at least four, we have about Vigon, Bebron, Vortex, Romson, Arrow, and you have one more, another couple of more kits. Without naming anybody, at least 4 companies, the tip of the tube needle is very sharp, very sharp. So when the tip of the tube is very sharp, the moment you're threading the catheter and the catheter does not go in, and you try to pull out, it snaps. And some of the companies' catheter is ideal, they're a little blunt. You can't puncture the skin also. Those are the ideal catheter, ideal tube needles. And those catheters probably you can, but still I won't recommend that you pull out the catheter alone. You have to pull out the assembly. Very, very important. Very important. And arrow catheters are nothing but the wire reinforced catheters.
Yes, sir.
I don't know that the incidence of blood type is less with these catheters. But again, I must tell you that these catheters are the easiest to break, because these wire reinforced catheters, again, there are certain areas in the catheter which are without wire for you to see whether there is any blood or CSF. So they during the length of the catheter, every 5 centimeters, like first 10 centimeters is wire, then 2 millimeters is a area without wire for you to visually inspect whether it is any CSF or blood is coming. And these are the easily break off points. So when you're trying to pull the catheter can get snap off at these weak points. So arrow catheters has a tendency to snap off. So one of the ways of preventing snapping of catheter is, if the catheter is not coming out, what we do is inject saline into the catheter, to the epidural catheter. It becomes stiff, and then you try to pull out the catheter with a patient in flex position, and majority of the time it comes out. Many a times, or sometimes there have been few case reports where patient is not totally flexed because of whatever reason, pain. So in that case, probably if you give little propofol to the patient in flex position, the ligaments they relax, and then you can pull it out. You can pull out the catheter.
So,
Yeah, Tower and company was the other company which I was not.
yeah.
Yeah, in fact, we have used this catheter of Torrent company, which comes with the side bulb. In fact, Romson was the first which came up in 2007 with a side bulb, pink colored needle, very badly designed this thing. But nevertheless, so the Torrent is a little sophisticated this design. Yes, it helps us. It helps us in identifying the space, two-hand technique. So you have Episure, you have Epimatic, you have Torrent, you have illuminating bulb, and you have so many needles devices which are there available in the market currently, which helps in identifying the space. The built-in balloon, either you can inject air or saline, and it's a two-hand technique. As you advance the QE needle, the balloon collapses, the side balloon. If it's the air, it collapses. If it's saline, it just goes into the epidural space. So, yes.
Sir, your what I can say it, your PPH simulations are happening around the states. Related to that, we are from ISA City branch are really grateful that if you come on our ISA City
We'll plan on simulation
last time.
workshop.
So I will contact you on that
certainly,
note.
certainly, sir.
Future.
Totally.
Related to, sir, in endoscopic procedures, what type of nowadays what you use for routine GI scopies or
The protocol is, fortunately, our surgeons are very fast. The upper GI endoscopy is done within 1.5 minutes. So what we do is we just spray the oral cavity with 10% spray, 3 to 4 puffs, and we ask the patient to swallow. So there is a topical anesthesia already has happened in the cavity. I mean, in the oropharynx,
oral cavities? Yes.
hypopharynx, and they swallow. Yes, it's a little bitter taste, pleasant odor. And what we do is we just inject propofol, and in the moment the patient goes into apnea because of propofol,
Yes.
we ask the gastroenterologist to insert the scope, and then subsequently the patient regains the breathing. And by the time the patient comes out, we just inject little more, so probably 8 to 10 ml of propofol. And by the time the scope is over. But yes, before giving propofol, what we do is we put a nasal prong 1 to 2 minutes before nasal oxygen and nasal capnometry, so that the patient keeps breathing during the scopy and there is no desaturation. So
Before that, yes, sir. Please continue.
for upper GI scopies and colonoscopies, just propofol alone suffices. For ERCPs, yes, we give dexmedetomidine, but it's propofol and fentanyl combination, because ERCPs on an average takes about 7 to 20 minutes, depending on the type of gastroenterologist you have. And if you're doing stenting or removing stenting or pancreatic calculi extraction or any CBD calculi extraction, it may take a little longer time. But average time is about 20-25 minutes, 7 minutes to 15-20 minutes. So we just give propofol with dexmedetomidine infusion, which is on, and nasal oxygen and nasal capnometry.
With this, any pre-medication with this, or perioperative, any what we can say, atropine or other things that
Glyco, we keep it ready, we don't give it. We keep it ready, available. The glycoatropine, ephedrine, adrenaline, phenylephrine, the syringes, the loaded and kept. Hardly we use it. And majority of the time, because the topical anesthesia works wonders actually, that the insertion stimulus is blunted, and patient comes out quite well. Yes.
your work is very vast. You work in almost your 3 to 4 hospitals. You are director, and you're working on ops and even GI and neuro also.
So of late, a lot of GI and surgical onco, but I do go to Fernandez at least once a week because we have this fellowship program, and we keep getting some requests for me to come there. So for those cases,
we needed in a near future for this your PPH simulation.
We'll do one simulation workshop with PPH and high risk obstetrics. We can do that.
Yes, sir. Really thankful for this. I feel so overall no questions from audience, and this one is very wonderful evening for all of us, that you speak
And
on Pdph. This is really sore topic for us, all of us.
I realized that honestly, I thought I totally forgot today, Sachin. And I did receive a message 3 days back. And I wanted to modify the presentation. This was a presentation that I did at Ganga for a 10 minutes talk. It was just a 10 minutes talk.
Yes, yes.
So the other presentation is there, which is there. I got so which is an elaborate presentation, but I couldn't open that paucity of time. But anyway,
You can, sir. In near future, we will do one more case bit with you, sir.
no issues.
If your time allows you.
Always a pleasure. Always a pleasure, sir. Thank you
So,
very much.
yes, sir. Thank you, sir. Thank you, all of you, and thanks from almost everyone is thanking you in
Yeah.
chat box. Yes, yes.
Thank you so much.
So really, I will feel great that this evening I meet you,
We'll plan
great
something
stalwart
in
like you.
December. Yeah,
Yes,
estimation whenever you feel, whenever you say.
yes, yes. I will contact. Sir.
Okay.
So
Thank
I will conclude this session with great note that we will meet in near future with at Nanded also in our case meet also, sir. So
certainly, sir.
yes, sir. Thank you, sir. Thanks.